Our last speaker for this session is going to be Dr. Del Nido. He's going to tell us about how to keep the heart alive during these complex procedures. I remember we had about 3 years in a row, there was 2 or 3 papers on Del Nido at the plenary session of the AATS. They've fallen off of the plenary session. Now they're in like Tuesday afternoon, but give us an update.
Probably. When they return to the research program, then we were in big trouble. Well, first of all, thank you for inviting me, Tyrone, wherever he is. It's an honor for me to do this and to talk about it. I wanted to talk about congenital mitral valve disease, but he said, no. I wanted to talk about uricardioplasia. And the main reason is because people don't use it well and get into trouble. So a little bit about my experience with Tyrone. I had just finished the lab when I spent the whole time operating on dogs trying to develop cardioplegia. First rotation with Tyrone, and I scrub in on my first case, and all I have to do is just keep my hands out of his way. And I say to myself, why the hell does he need cardioplegia? You know, he's done in about 20 minutes, and you can just clamp the heart and it'll be fine. Well, lo and behold, the majority of us still need cardioplegia. So this is where we got started. I think I need the clicker.
It's right there. Right.
Oh, here it is. Okay.
The
green button. These are my disclosures. So I wanted to cover a little bit about the basics because I think people forget the basics. And if you don't think about it, at least while you're having these very, very complex, long procedures, you're going to get yourself into trouble. So what's the goal of myocardial ischemia? Well, first you have to understand what happens to the cell when you induce ischemia, and more importantly, when you reperfuse. The normal myocardial cell keeps an enormous gradient of sodium and calcium out of the cell. So the gradient of sodium outside the cell versus inside is about 8 to 1. Calcium is about 1,200 to 1. And so there's this huge mechanism that the cell has built to keep that calcium out. Why? The calcium is what triggers contraction, which is critical, obviously, for its function, but the calcium also is extremely dangerous for the mitochondria. If the calcium enters the mitochondria, it begins to damage it immediately. You get calcium phosphate precipitation, the mitochondria dying, then your cell dies. And so maintaining that gradient is hugely important. During ischemia, obviously, those mechanisms, which are very high energy requiring mechanisms, are no longer functional. So you have to rely on other activity in order to accomplish this. The mitochondria, as everybody knows, is the critical engine of the heart cell. It's the critical engine of many of the active cells. But the beauty of the mitochondria is that it's able to generate ATP at a level 32 times higher than by simple glycolysis. So for every every mole of glucose that gets in, or pyruvate that gets into the mitochondria, it generates 32 moles of ATP, whereas everything else generates about 1 or 2. So it's an incredibly efficient system, but it's extremely sensitive, and it's sensitive primarily to pH gradients and to calcium. So all of these mechanisms are present during ischemia. On reperfusion, however, is when most of that injury really occurs. Because you've got a cell that's deplete of ATP and high-energy phosphates, and suddenly you're just pushing back a lot of sodium and calcium back into the cell or into the tissue around the cell, and it'll get inside. And once it gets inside at a high enough level that the pumps can't keep up with it, the mitochondria will die and the cell will die. So what are the risk factors that we have to keep in mind? Things like chronic ischemia is clear. We know that those patients have markedly devoid ability to maintain high-energy phosphates. Hypertrophy is another one. Hypertrophy fundamentally is a problem of diffusion of oxygen to the myocardium. The distance between capillaries in the myocardial cells is about 200 microns in many of the severe hypertrophy. That's about the limit of diffusion. And so these cells are chronically hypoxic. And then other drugs that induce a lot of work, catecholamines, digoxin. And then the other one that we always forget is senescence. senescence is associated also with degeneration because your mitochondria eventually die, and your cell's ability to regenerate them eventually goes away. So what are the aims of myocardial protection? Obviously, reduce oxygen demand, prevent sodium and calcium entry, prevent swelling of the mitochondria, because with swelling will actually begin to disrupt it, and in some way try to maintain high-energy phosphates. And that latter one was the one that everybody tried to pursue in the 80s and 90s and even early 2000s, and really hasn't been terribly successfully demonstrated. It's hard to get around just basic biology. And if you take nothing out of this talk, this is probably the most important slide. Temperature makes a difference. And a little bit of drop in temperature makes a big difference. So this is work that was done in dogs. This was done at Duke in the 70s. And what they did is they looked at oxygen consumption versus temperature and whether the heart was beating. And you get the vast majority of your gain by just stopping the heart and getting it empty. You get about 60 to 70% of the gain in protection just by keeping it empty and stopping it from beating. You gain additional protection by hypothermia, obviously. But the vast majority of you get in the first maybe 10 degrees. So by the time you get into the 30 range or even high 20s, you gained most of your protection. Why is that important? Well, in a lot of the procedures, and especially in the adult world, people are using normothermia as their bypass technique. And if the heart is surrounded by normothermic tissue, guess what happens? There's no blood flow to wash or cardioplegia to wash the heat away. The heart will warm up. It'll begin to die. And you don't have to cool it very much. If you just keep it somewhere in the 20s, it'll be fine. It'll be fine for a very long period of time. So most of your protection is here. This is the vast, probably the single most important thing that you can do to protect the heart. Other things that are important, the method of arrest. Typically we use depolarizing agents, which is potassium. That's a depolarizing agent. The problem, it stops the heart very quickly, but the problem is opens the sodium channels. And if you open the sodium channels, guess what? Sodium will get in. And if sodium gets in, calcium will get in. So what's the other way of doing it? You can hyperpolarize the cells. And the way you do that is by blocking the sodium channels. And there are drugs that do that. The earliest drug that was used for that was Procaine, which was in St. Thomas cardioplegia very early on in the 70s. We chose for our solution lidocaine simply because it's a longer-acting sodium channel blocker, but you can overdo it. It is toxic if you give too much of it. So if you insist on giving multi-dosing, take the lidocaine out. It will cause toxicity if you're not careful. So again, the aims of the myocardial protection, but then how do we preserve ATP preservation during ischemia? This is something that Jerry Buckberg worked on for years. A lot of folks have really worked on for years. Then they felt that oxidative phosphorylation, getting blood in, getting oxygen in, somehow was going to maintain it. The problem is that it only works for a minute or two while you're infusing it. After that, there's no more oxygen, there's no more oxidative phosphorylation. So this doesn't really work. And there's very little demonstration that it ever made any difference. So what else can you do? Well, there is aerobic metabolism, or anaerobic metabolism, I should say, which is glycolysis. And the problem with glycolysis is that it gets inhibited very quickly as soon as the cell gets acidotic. So proton accumulation is the main inhibitor, and that blocks glucose breakdown. You can generate a fair bit of ATP with glycolysis alone, but you need to prevent this. And so what can you do? You can sop up the hydrogen. You can use buffers. Bicarbonate is the most common one. Histidine happens to be the best. Histidine is an amino acid, the most ubiquitous amino acid in the cell. And there are cardioplegias, in fact, in Europe, very commonly used, that have a high concentration of histidine. That's the reason. It's because it's a very good buffer. We use red cells. You don't need a lot of them. It has carbonic anhydrase. It's an enzyme. It'll actually take protons and combine them with CO2 and make water. And that being an enzyme is actually very active even though you have a very low concentration. So we have red cells in the cardioplegia, and that concentration is really a very dilute amount. It's about 7%. The dosage, I think, is important. If in the normal, otherwise healthy heart, 20 mLs per kilogram is enough. But rarely are we operating on normal hearts. And if you have a very sick or very hypertrophy heart, you have to give more. How often do you give it? This is a question I get asked virtually every time somebody asks me about this. Always keep the heart cool. If you need to give an additional dose because the heart is warming up, give an additional dose. Be cognizant that there's lidocaine in there and that you're going to cause toxicity if you give it every 10, 15 minutes. But if you give it every 45 or 60 minutes, it's not going to be toxic. More importantly, it'll keep the heart cold. It'll keep it stopped. And that's been my recommendation forever, although I don't know how many people listen. Why single dose? Well, in pediatrics, and the reason why we use a single dose is that the infant heart, particularly the vasculature, is extremely sensitive to shear force injury. In other words, if you blast cardioplegia in, you'll destroy the endothelial cells. You'll literally shear them off the vasculature. And especially after they've been ischemic for a while, it's very easy to shear off the... And if you look at in newborn hearts, after you've given a lot of cardioplegia, after you reperfuse, you see petechiae all over the heart. Guess what? That's capillary ruptures from your injury of the endothelium. So that's why we don't, I prefer not to give it in very small infants a second dose. That doesn't apply necessarily to adults, okay? But this was developed for pediatrics. So the risks that you're running by giving only once every hour or once every hour and a half is that the heart will rewarm, that you'll have inadequate distribution of your cardioplegia if you have adults with coronary artery disease, but there are ways to get around that. And how long is too long? Well, you have to think of the patient that you're dealing with. If you're dealing with a hypertrophied heart, chronically ischemic, or an elderly patient, you have to do more. You have to give more frequently. So you need to understand the strategy of single dose. You need to look at the effect or think about the effects of ischemia and multidosing, again, primarily on young children. And so with that, I'll just summarize. Temperature, not that cold. Anything 20 or less, even mid-20s, is fine. It will protect the heart for a very long period of time. Hyperpolar arrest, I think, is important. The administration, it doesn't matter how you give it. There have been studies with retrograde, antegrade, through grafts, all kinds of different ways. I do think, though, that if you're dealing with a hypertrophied heart, more cardioplegia at the initial time is better. And so for that, I would give it in the range of about 30 mLs per kilogram, and particularly if you think you're dealing with vulnerable myocardium. So practical lessons, simple measures achieve the most positive effect. Hypothermia is still, we haven't gotten around basic physics. Low temperature is the most important thing. And if the heart, because it's surrounded by warm tissue, warms up, you have to do something. Topical cooling, give more cardioplegia, do something, but don't let it warm up, especially the right ventricle. The right ventricle is often the most vulnerable component because it's very thin-walled and very easy to rewarm. How often should we give cardioplegia? Maintain arrest, maintain hypothermia, the principles. I would recommend redosing every 60 minutes or 45 minutes if you're uncomfortable. But remember, you can't go forever. And I've seen cross-clamp times of over 4 hours and people wondering why the heart isn't working afterwards. Well, nothing's going to help you then, okay? And so that's probably the most important lesson. Thank you.
Thank you, Dr. Del Nido. We've got about 5 minutes of discussion time if